This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the journal Clinical Interventions in Aging, published in 2026. The paper is titled Percutaneous Endoscopic Decompression versus Non-Operative Care for Radicular Pain in the Oldest Old with Lumbar Stenosis, a target trial emulation focusing on pain relief and deprescribing.
This is a timely topic, Alara. As our population ages, we're seeing more and more of the oldest old, patients 80 years and older, presenting with symptomatic lumbar spinal stenosis, or LSS. Historically, we've been hesitant to offer surgery to this group because of concerns over multimorbidity, frailty, and the risks of general anesthesia.
Exactly, Dr. Eris. The authors point out a therapeutic inertia or undermanagement in this demographic. We often default to non-operative care because we're afraid of the complications of open surgery, even though the evidence for conservative management in octogenarians is actually quite low quality.
And that's where this study comes in. It uses a target trial emulation framework. For our residents listening, could you briefly explain why they chose that design instead of a traditional retrospective cohort?
Great question. A target trial emulation is a methodological approach that uses observational data to approximate a randomized controlled trial. It helps account for common biases in retrospective work by setting a clear time zero, in this case, the date following a confirmatory diagnostic nerve root block, and applying strict eligibility criteria at that moment. It's about as close as you can get to an RCT when a prospective trial isn't available.
They looked at 143 patients, all 80 or older, with unilateral radicular pain and MRI-confirmed LSS. What was the breakdown of the interventions?
So 75 patients underwent percutaneous transforaminal endoscopic decompression, or PTED, and 68 received structured non-operative care. Now, the PTED was specifically performed under local anesthesia. They focused on a transforaminal approach to allow for targeted resection of the hypertrophic ligamentum flavum and partial undercutting of the facet joint.
That's a key neurosurgical point. In these older patients, we aren't necessarily looking for a massive multi-level reconstruction. PTED allows for an indirect decompression of the central canal while directly addressing the lateral recess and foraminal stenosis. But let's talk about the diagnostic protocol. I noticed they were very specific about the nerve root block.
They were. Every patient had to have an ultrasound-guided diagnostic nerve root block. If they didn't have a positive response to that block, meaning effective pain relief, they were excluded from the study. This ensures that the surgical or conservative treatment was actually targeting the correct symptomatic level, which is vital when you have an 85-year-old with multi-level degenerative changes on MRI.
It's about clinical radiological correlation. Now, the primary outcome here was 90-day comprehensive treatment failure. That's a composite endpoint. What did that actually include?
It included unplanned rehospitalization or treatment escalation due to uncontrolled pain or any serious complications. Essentially, it tracks whether the initial management strategy actually worked in the short term. The results were quite striking. The PTED group had a failure rate of only 16%, compared to 44.1% in the non-operative care group.
That's a massive difference. If I recall the stats from the paper, after multivariate adjustment and inverse probability weighting, the adjusted odds ratio for treatment failure with PTED was 0.18.
Yes, and the number needed to treat, or NNT, was just 3.7. For every 4 patients you treat with PTED instead of conservative care, you prevent 1 comprehensive treatment failure. The authors noted that this was primarily driven by pain-related failure.
This is what we see in the clinic. Patients in the non-operative group often end up in the ER or back in the clinic within 3 months because the physical therapy and pharmacotherapy just aren't cutting it for severe stenosis. But what about the risks? We always worry that surgery might cause more harm than good in a 90-year-old.
That's the interesting part. The complication-related failure did not differ significantly between the groups. When they looked at the benefit-risk ratio, it was 6.6 to 1 in favor of PTE. Because it's done under local anesthesia with minimal tissue dissection, the vulnerable demographic risks we usually associate with spine surgery were significantly mitigated.
Let's dive deeper into the secondary outcomes, because there's a concept here that we don't often talk about in neurosurgery: deprescribing.
I found this to be the most novel part of the study. We know that older patients are often on a cocktail of analgesics, NSAIDs, gabapentinoids, sometimes opioids, which carry huge risks for falls, cognitive decline, and renal issues. The study tracked polypharmacy at 12 months.
And what did they find?
The prevalence of polypharmacy was significantly lower in the PTED group at 1 year, with an adjusted odds ratio of 0.14. By effectively treating the pain source via decompression, they were able to reduce the medication burden. This deprescribing benefit suggests that PT-ED isn't just about the spine. It's about the patient's overall geriatric health profile.
It's a holistic view of surgical success. Instead of just looking at the MRI or the leg pain, we're looking at whether we reduced the number of potentially harmful drugs the patient is taking. Speaking of pain, did the functional improvements hold up at the 1-year mark?
They did. At 12 months, the PT-ED patients showed a greater improvement in the Oswestry Disability Index, or ODI. The adjusted difference was minus 8.92 points compared to the non-operative group. So the benefits weren't just a short-term placebo effect from the procedure. They were sustained functional gains.
For our residents, it's worth noting the technical aspect mentioned in the paper. The authors used the transforaminal approach to resect the ligamentum flavum. In the oldest old, the ligament is often the primary culprit of central and lateral stenosis. By doing this endoscopically, we preserve the posterior elements and the midline structures, which is crucial for maintaining stability in an already degenerative spine.
And doing it under local anesthesia is a game changer for the ASA3 patients. The study excluded ASA4 patients, but they still had a very elderly cohort. Dr. Aris, how does this change your approach when you see an 82-year-old with unilateral radiculopathy?
It reinforces the idea that we shouldn't dismiss surgery based on age alone. If we can identify a clear symptomatic level with a nerve root block, PT-ED offers a high-value, low-risk intervention. The study shows that conservative management might actually be the riskier path if it leads to 44% failure and continued polypharmacy.
Exactly. The paper concludes that while non-operative care is often the default, it may actually represent undermanagement. They advocate for PT-ED to be considered a first-line therapeutic option for carefully selected patients.
That careful selection is key. Let's look at the inclusion criteria again. These weren't just any patients with back pain. They had imaging-confirmed stenosis, unilateral symptoms, and they had already failed 3 months of conservative care before being considered for the study time 0.
Right. And they had to have a negative history of cognitive impairment and no severe hip or knee osteoarthritis that could confound the assessment of their walking and pain.
It's a very clean study design. Of course, as a target trial emulation using retrospective data, it's not a prospective RCT, but the authors argue, and I agree, that these findings justify the need for one.
Before we wrap up, I wanted to mention the subgroup analyses. They found that the treatment effect was consistent across various patient characteristics. Whether the patient was 80 or 90 or had different baseline pain levels, the advantage of PT-ED over non-operative care remained stable.
That's reassuring. It suggests that the benefit of decompression is robust. For our audience of surgeons and residents, the takeaway here is that minimally invasive endoscopic techniques like PT-ED are expanding the surgical window for the elderly. We can offer meaningful pain relief and functional improvement while actually simplifying their medical management by reducing their pill burden.
It's a great example of how neurosurgical intervention can intersect with geriatric medicine.
Well, that's all the time we have for today. The study is a significant contribution to our understanding of LSS management in the oldest old. If you want to read the full paper, look for it in Clinical Interventions in Aging 2026.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Goodbye.